who is going to tell us about the logical approach in orbital tumors. Dr.
Thank you,
Grover.
Pradeep. Before we venture into muscles and squint, okay. So you heard that excellent overview of congenital and acquired ptosis by Fairuz. We move to orbital tumors. This again is an area which you will encounter in your examinations whenever a case is available. It would be a long case for you. So just as ptosis is. So I would like to take the opportunity to thank opportunity to thank the scientific committee for this opportunity to make this presentation. If you just take this out and put in, वो काम कर जाता है कई बार.
The slide is going outside the orbit.
Yeah. Okay, this is much better now. So can we have the time reset to 25? 18 now. Okay, 3 minutes for Pradeep. Okay, so when we look at orbital tumors, the things that we need to know are, one, look at the basic anatomy of the orbit, how an orbital tumor would present because of the anatomical factors, and what the different presentations could be as a result of the anatomical change that it brings about. Then we look at the clinical diagnosis. The relevant investigations are very important to help us reach a diagnosis, which in turn lead us to the appropriate management. Now, we know the volume of the orbit is only 30 milliliters, and globe occupies only 1/4 to 1/5 of that. And the rest of it is the orbital spaces. And what are the spaces? Within the extraocular muscle is the intracorneal space. And outside the muscles, what is this? Extracorneal space. And just under the bone is the potential subperiosteal space. Where is the fourth space? Subtenons, which is again a potential space. So we have these spaces. Depending on the location of the pathology, they would present differently. If they're intracorneal or intracorneal with extracorneal extension or predominantly extracorneal, the presentation would vary. So when we evaluate the cases of proptosis, as elsewhere, history taking is critical. So is examination, and investigations are very important in the orbit. Now, age and sex is very important. You know that diseases of infancy are different from those of an adult, and those in pediatric age group are again quite different from those in the adults. Certain diseases have predisposition for a female sex or male sex. Then we look at the symptoms that have occurred as a result of structural changes and as a result of alteration of physiology. Time period of happening of things is again the third important factor. Systemic involvement in several diseases in the orbit is again very important, and family history offers you important clues in orbital diagnosis. So if you have something happening over a period of minutes, what pathology would you think of? An acute hemorrhage? Hemorrhage within a tumor could be a factor which would occur within minutes, or an acute allergic reaction, edema taking place in the orbit. If it occurs over a period of days, what would you think of? 2 days, 1 day? An inflammation, obviously. If it occurs over a period of, let's say, over weeks, probably a rapidly growing malignancy over months and years, maybe a benign pathology. So these would help your computer eliminate lot of diseases. Once you've seen the age group, once you've seen the time course, you would only be thinking of certain pathologies. So that is the importance of history. Then look at the kind of changes that have been produced. What kind of displacement has taken place? What kind of protrusion has taken place? Whether there have been sensory changes or motor changes, these are the functional changes that have taken place. And whether there is an associated dry eye, whether there is a greater watering, what kind of swelling or redness is present. These are all very important clues in the history which will lead you to a diagnosis. Associated systemic conditions like thyroid eye disease or and other features of lymphomas are again very important clues. Several diseases would have a family history. So once you have the history, you have zeroed in on certain things, and your examination would help you to go further and pinpoint the pathology. Now, general assessment, as we always say, is important. Ophthalmic examination, we've already seen how the different ocular structures could be affected, and systemic examination is important. So one, orientation, facial symmetry, and the test where the patient's cooperation is important, the psychophysical test, visual acuity, visual fields. We know that the pressure over the nerve could affect visual fields and visual acuity. We need to look at the color vision, which may be an early clue to pressure and effect on the nerve, optic nerve. Corneal exposure may be a manifestation of the proptosis caused by the tumor. Changes in binocular vision, diplopia, ocular motility, and the force duction test, which is again important to help you distinguish a paretic pathology from a restrictive pathology. Eyelid changes secondary to the orbital pathology are common, which you need to look for. You need to look for the anterior segment examination, particularly the pupils, and exposure. Intraocular pressure gets affected in several orbital diseases where there is a diffuse pathology because of rise of intraocular pressure, such as in thyroid exophthalmos. And look for pressure signs. When a tumor intraconal grows, presses on the globe, you would see disc edema, you may see choroidal folds, retinal folds. Assessment of exophthalmos again is important. Measurement of dystopia, whether the globe has moved out, in, down, or up. And if you use two scales, you can quantify that. You also need to measure the exophthalmos, a simple device like ludes, or measurement within hurtles. Hurtles, you must know the procedure. You must also record the bar reading every time so that the readings taken on subsequent occasions are comparable. Orbital assessment obviously is important. So one, orbital tension is important to see whether there is an increased resistance within the orbit, which would indicate a solid tumor, or if there is a very minimal resistance, it may indicate a compressible tumor or may indicate a minimum pathology. You need to examine the orbital area just as you would do for a tumor elsewhere or a mass elsewhere, as you learned with your K-Das or your Hamilton-Bailey. So look at all those features. And Valsalva's maneuver is important in orbital varices. Auscultation is important in the keratico-cavernous fistulas that Fairuz was talking about. And systemic examination to look for cafeolar spots, other hemangiomas, other signs of systemic diseases. Laboratory investigations offer a clue in certain parasitic infestations, certain other pathologies, and investigations, especially imaging, have a critical role in the evaluation. Plain X-ray orbit is rarely done, but you theoretically need to know about the various views that are useful to you. Waters' view is often very important and does offer you certain clues, but the most important is to know these changes that take place, which are important both in plain X-rays and in CTs. So orbital enlargement, symmetrical or asymmetrical, presence of calcification, presence of enlargement of superior orbital fissure, or of optic phenomena which can be uniform or irregular, may all offer important clues. Similarly, changes in the bone density, which may include hyperostosis, osteolysis, which may be diffuse or localized. And similarly, the soft tissue changes in the orbits and surrounding areas may be very important. So CT scan often is still a method of choice in orbital diagnosis, where you look at the contrast differences based on the densities obtained on passage of X-rays through the tissues. So the different densities which you measure as Hansfeld units are important, and these are the attenuation values which you look at. And it is important to use advanced spiral techniques or the more advanced techniques, and use finer cuts where indicated to get the right kind of idea. And you can have those where the tissues are highlighted better, or where the bones are highlighted better, the bone density windows and the tissue density windows. In MR, it is essentially the proton density that you are measuring, and the more advanced machines can give you 0.6 to 1 millimeter thin slices, and you have several newer fat suppression techniques, development of stir sequences, development of flare. You need to be aware of these to utilize, to make the best use of these films. MR angiography, MR venography may be indicated in relevant cases, and you need to distinguish the various views that you get. You have the T1 weighted images where the vitreous is light, has the same density as the fat. You have the eggshell cuts, you have the coronal cuts, the sagittal view, and you have the T2 weighted images where the vitreous appears white. So you have to look at all these differential characteristics in T1 weighted, T2 weighted, in order to make an appropriate diagnosis. And these imaging techniques have revolutionized your diagnostic ability. CT scan versus MRI, they can both be complementary, but CT is often preferred if you want to look at the surrounding areas as well, including paranasal sinuses, surrounding pathology, and particularly if you want to look at changes in the bony structures. But MRI provides greater details about soft tissues, and we'll also look at the better resolution for cranial purposes. Of course, there are contraindications for MRI like cardiac pacemakers and any metallic thing. So MRI not just has a better visualization near the orbital apex and cavernous sinus region, but also in intracranial lesions, and is becoming important in pediatric cases, particularly in retinoblastomas, where you want to avoid a CT because of the risk of radiation exposures. So complementary because they can give additional information about the nature of pathology. Ultrasonography is a useful technique because both with A scan and with B scan, you can look at it in your clinic, you can do serial examinations, and you can do tissue characterization with the help of ultrasonography. Biopsy is again the most important factor in tissue identification. Fine needle biopsy is only indicated in cases where a differentiation between an inflammation and a malignancy needs to be made. In many other cases, you would do an incisional biopsy. And wherever a complete excision is possible, the choice is excisional biopsy. And you can really make a good diagnosis, final diagnosis, based on histopathology and immunohistochemistry. Let's look at some of the tumors in different age groups. Let's look at the spectrum of tumors or conditions which affect infancy, childhood, and adults before we go on to the surgical management. In infants, you need to look at conditions such as craniosynostosis, where you have changes in the orbital structure because of the craniostenosis, premature closure of the sutures, encephalocele or meningoencephalocele, and microphthalmos with cyst again may be a presentation. You may have teratomas, capillary hemangiomas, metastatic retinoblastomas, and orbital retinoblastomas. So these are the conditions which present in early childhood, early infancy or childhood. Now this is an encephalocele here. In children, you need to exclude inflammatory disorders if you have to make a diagnosis of a tumor. Parasitic infestations may present very much like tumors, and the various tumors of childhood include all these entities, some of which we can look at: a dermoid, external angular, internal angular, orbital. All these are important. Optic nerve gliomas, meningiomas, plexiform neurofibromas with many systemic associations, neurofibromas are all important. Vascular lesions are again very important both in childhood and in adulthood, and you need to be aware of the new International Society for the Study of Vascular Anomalies classification, which classifies them into vascular tumors, slow flow vascular malformations, and fast flow malformations. So the classical descriptions as cavernous hemangioma, capillary hemangioma are now more often referred to as slow flow, fast flow malformations, and you need to be aware of this classification. So you may have a capillary hemangioma which may be associated with similar lesions elsewhere in the body. You may have venous malformations or lymphovenous malformations, earlier called lymphangiomas. They are now lymphatic malformations. In adults, you need to have a differentiation of tumors from thyroid exophthalmos, which can be the commonest cause even of a unilateral proptosis. Vascular lesions in adults are important. Again, a lymphovenous malformation, a keratocavernous fistula, varices, tumors which may again be primary, orbital tumors, lacrimal gland tumors again differently, and then secondary tumors which may come from surrounding structures and less commonly as metastasis. One of the commoner ones is a pleomorphic adenoma of the lacrimal gland, but you may have malignancy in a young child, a young adult with features of pain added to proptosis, relatively rapid growth, and adenoid cystic carcinoma. Orbital dermoids may present in adults, neurofibromas, schwannomas, lymphomas in the elderly. So these all need to be looked at. You have to look at the specific age group. You have to look at the kind of pathology that you see on imaging to make a differential diagnosis in your mind before you decide on the management. Lid tumors, frontoethmoidal mucoceles, tumors from the frontal sinus may all come into the orbit. Pathologies in the maxillary sinus, they may all affect the orbit. That brings us to the approaches to the orbit. Well, important is for you to know the choice is made based on the surgical space occupied, size and location of the lesion, the suspected pathology. Your approach becomes different for a resectable tumor like a benign, well-defined tumor versus a poorly defined malignancy where your target may only be an incisional biopsy and further management with radiotherapy or chemotherapy. So the goal of surgery will accordingly vary. You always try and take the most direct approach. You try avoid crossing the optic nerve. If it is on the lateral side, you would prefer that. If it is in anteromedial, you would go anteromedially. And you try and take an aesthetic approach, hide skin incisions, avoid bone removal where you can. So minimally invasive approaches and aesthetically appropriate approaches have become the buzzword in surgery of the orbit. So we'll briefly look at the various options. The anterior orbitotomies, which can be through the skin, through the conjunctiva, and when you combine an inferior conjunctival or pharyngeal approach with a lateral canthotomy and cantholysis, it becomes a swinging eyelid approach. Medially, you can do a transcaruncular approach. For lateral or large tumors where bony removal may also be needed, a lateral approach or a lateral orbitotomy is done. For those with combined intracranial extension or very close to the orbital apex, you do a transcranial approach, or sometimes you need to combine the approaches. So the commonly used approaches now for orbitotomy are these that stay aesthetic. You can use a Burke's incision, which is at the lateral canthus. You can use a lid crease incision, or more often, the lid crease incision is now preferred for lateral orbitotomy. For the anterior orbitotomy, you can use a Subbrow approach, or this is a Subbrow approach where a tumor has been removed and the patient has this kind of a pathology in the superior orbit has been taken care of by a Subbrow approach. Eyelid crease approach is again a very important approach because it causes no scar. Your scar can be hidden within the line of the lid crease. The mass like a medial extraconal mass can be taken care of by an eyelid crease incision, as you see here. But transconjunctival approaches are now used much more often, like this inferior orbital mass. Now, you would very easily go in from the orbit, from the inferior fornix, and get rid of this mass, as you see here. So, superomedial conjunctival approach has been used here for this tumor. Lateral orbitotomy, upper eyelid crease incision is now the favored approach. Traditionally, you had the Stallard-Wright incision or the Burke-Reese incision. But now upper eyelid crease incision is very much the favored incision because of minimum scarring and least possible dissection. We'll very briefly look at this video where we're going through the eyelid crease and we have incised the muscle, orbicularis muscle, defined the lateral orbital bone. This is the marking of the incision that we're going to make in the periosteum. Lift up the periosteum to go into the subperiosteal space. Then you dissect the temporalis muscle. Once you've gone lifted up the periosteum, you can do your osteotomies by using a striker saw or one of those automated saws, and then you remove the bone, give an incision in the periosteum, expose the tumor, dissect by blunt dissection, take out the tumor, use a cryoprobe for the final dissection, and then you can carry out a closure. The transcranial orbitotomies are indicated only for the lesions which are very close to the apex or with intracranial extension, and a bicoronal approach is used along with a neurosurgeon for a transfrontal craniotomy like this. And after an osteotomy is made, the tumor is exposed and removed. Those with very large tumors may require a lateral approach to be combined with an anterior approach, or a lateral approach to be combined with an intracranial approach. And these combined approaches help you in removing multi-lobed or very much larger tumors. To conclude, appropriate evaluation, including a good history taking and examination, is the key to decision making in orbital tumors. Investigations, especially imaging, is very important in the orbital diagnosis. The approaches to orbital tumors are increasingly minimally invasive. They provide an excellent exposure for safe removal of tumors while retaining the aesthetics of the patient, which is important for his confidence and his well-being and his ability to face the world. Thank you very much.
Thank you, Professor Grover. I think